Gama, vous pouvez commencer. Hein?
Good morning, everybody.
Good morning.
Welcome you in Monastir, Tunisia, for this new session of Pafcic. And we are happy to join our friends, our colleagues from Europe, who will share the session with us. And I think we're going to start with the presentation with the case from Hospital Rabta, who will show us percutaneous closure of VSD. Can you please present the case, Sami?
Good morning, everybody. Welcome to Rapta Cat Lab. All the team here is honored by to participate to this Congress. Before beginning, I want to tell some word about Professor Mishmesh, who is a great interventional cardiologist in Tunisia, and all that you are watching or seeing now he is in a great part responsible of it. So today we have the challenge to close ventricular septal defect of 4 years girl, and in this intervention we have the head who I will assist is Dr. Farhati and Dr. Mraif with ETO, and I keep her to my place to present the case.
Good morning, everybody. So today we have a girl of 3 years. She's born in May 2017. Her mom had a normal pregnancy and delivery. She was asymptomatic in birth. Just in the few months, in the first month of life, she began to have difficulty of feeding. She was dysphoric and sweating when she feeds. And the diagnosis of ventricular septal defect was made at the age of 3 months by revealing a murmur by her pediatrician, and she had immediately an echo which revealed this ventricular septal defect. So the girl was followed up by serial echocardiography, but there was no spontaneous closure, and the girl has a loss of weight, and she's symptomatic. So we made a TPE for the procedure.
Yeah, after next, next,
please.
Next. Next.
So we have a 5 millimeter ventricular septal defect, which is.
Are you sure? Sorry to disturb you. Are you showing presentation or echo pictures? Because we only see fluoroscopy at the moment.
We are showing slides of the presentation. There is no live. No, it's.
No, we are only seeing fluoroscopy.
We have a technical. There is a problem because.
If you share screen, perhaps that might do it. I don't know.
Share slides, please.
Because it's important. It's capital.
Otherwise, show the.
Okay. By ETO. Now, yes.
So this is
Il ne passe pas.
Still fluoroscopy and hands.
Of 5 millimeters, and it is 6 millimeters from the atrioventricular plan. So we have a ventricular dilatation, left ventricular dilatation. So we can show
the echo is going to be very important for us to see.
Yes, it's important. We cannot go on without echo. Pourquoi ça ne marche pas? Here's a feed. Here's a feed. Here's وريه له. وخر كده. وخر. إجا وخر. Oui.
Okay, that's better than any other method. So, okay.
This is with BD and Stella.
Now we need your sound a bit better, so either nearer the microphone.
Yes. C'est bon, vas-y. Tu peux parler, Fatih.
Yes. This is the septal defect on an apical view. So as we said, it's a 5 millimeter septal defect, which is 6 millimeters from the atrioventricular plan. It's quite regular. The left ventricular opening is 8 millimeters. And the ventricle, so we measured the flow rate ratio to 2.1 and the Z score to 2.2. So the left ventricle is dilated. So now we can show you the
Il est passé dans la série.
We don't hear you.
Your sound, your sound's not very good.
Oui, vas-y, calme.
So it's a procedure under general anesthesia. The patient will receive 100 units per kilo heparin after, and corticoids and antibiotics. So now we can show you the TEE and we can begin the procedure.
Okay.
We guess that the pulmonary pressure is normal or slightly high. Do you?
It's slightly high.
Okay.
لا خرجت هي خرجت مش انا ما يزني يقرب الميكرو.
This is a hydrophilic guide wire.
So what are you using to cross the VSD? Which sort of catheter and guide wire?
For French catheter.
Catheters. Yeah.
We use for French catheter.
Okay.
Pigtail?
Bon.
ER, isn't it?
No.
Yeah.
Yes, I think it's.
It doesn't look like pigtail. So it's JR or?
Yeah,
GR4.
Okay.
For French, GR catheter.
All right. Yeah. And Terumo wire or something else?
Terumo wire.
Is that the way you operate, Professor Qureshi? Or do you suggest something else?
Yeah, no, I was going to say, I don't know if Dr. Tin has joined us from Vietnam.
Film.
He has done hundreds of these.
Now we had across the
across the VSD,
VSD, and the guide wire is in the AP.
and we can see the angio, please.
On fait l'angio. Est-ce qu'on répète l'angio?
Okay.
Yeah.
Donc,
Ce qu'on a
there's a sufficient aortic rim, or and oui, yes.
Voilà. Est-ce que vous voyez la calibration?
Et donc,
we did a measurement.
Yeah.
5 millimeter.
Okay. One of the other things that we ought to look at is, I see that you've got a TOE probe down, is look at the aortic rim,
yes,
the tricuspid valve rim.
yes.
Mm-hmm.
We are monitoring by ETU.
Voilà. Voilà.
You are seeing the ETU or no?
No, we are seeing the angiogram measurements at the moment.
No. بدلني أنا مهم هذاك أنا ما عادش تصورني.
دور الإكران.
You are seeing her now?
No, not yet.
Here?
Yes.
But not in full screen.
Ouais, it's a problem. C'est un problème technique. Ça.
Yeah.
Okay, now we see it. So you're showing the VSD in a short axis view, really transesophageal. So do a left ventricular outflow tract view.
Long axe, 160. Voilà.
Voilà.
That's it. Yeah.
Yes.
Yes.
And also, if you show either split screen or black and white to see how much rim there is underneath the aortic valve.
Sans couleur. J'ai le mesure.
Okay, there's a very short rim, isn't there?
By 5 millimeters.
5 millimeter.
Yeah. Okay.
4 or 5 millimeters.
4 or 5
What
millimeters.
are your views on the rim and the size, and then the next steps?
Sorry, then. Yes. It's 4 or 5 millimeters.
Mm-hmm.
Yeah. So, what are your thoughts about next steps?
Next steps. We plan to closure by MFO device. If we can across retrogradely or anterogradely. The watch device we can use.
If you
size device.
If you have access to the MFO, that's very good then, isn't it? Because you can approach it.
Yes, we have MFO. MFO device.
I think we can attack
7.5. We have 9.7. We have and 10.8.
My impression so far is that if it's a 5 millimeter defect, then I would try 7.5 initially, because it seems to have reasonable rims.
Yes. Retrogradely, we can pass retrogradely.
And because if you pick a too large one, then the aortic rim may be insufficient, and the device will protrude onto the aortic valve leaflet. So
Yes.
it's worth a shorter one or smaller one first.
Yes.
But if you use a 7.5, I'll be inclined then to use it over a guide wire circuit antegradely. But if you have you done retrograde approach with these as well?
Yes, we have retrograde.
Okay, well that's fine. Whichever you're comfortable with, I think that's important.
Yes. Donc,
final,
now we use delivery sheet 5 5
7.
French, huh? We can use
Continue,
5 French. Very, very cheap.
I tend to, I would use one French bigger, or if you have to upsize the device, for example, you don't want to be changing the sheath. So assume that you might have to upsize and pick this sheath for the next size up.
Donc 6.
It weight
Hey,
15 kilos, the baby. Don't, it's the weight. We can use 6 French.
Yes, yes, that's all right. I think.
Okay.
5.
لا متحلش يا ودي. خليك 5 ولا 6؟
5.
6.
5. Oh, 6. 6. 6. خلي يبي. ما حتى الفايف ممكن.
If you have to upsize.
Okay.
On 5. Hit 5. Hit 5. We will try with
6 French.
And definitely you decide to close it retrogradely.
Yes. Donc we try with the 7.5 MFO device.
Yeah.
Okay.
J'ai cru qu'on avait que 5. On avait que 8. Bon, le désilé, il est. On change le désilé. On va enlever le désilé, hein. On n'a pas besoin de ça. Ouais. Ça y est, prêt? Vas-y. Prends, chute de.
Vas-y. اسمع l'autre 5 francs.
ايه هو 5 كيف اللي لا. ايه طيب حلو. ايه حلو.
Donc caméra.
Oui.
Okay.
Is there another alternative device to close this VSD, Professor Qureshi?
Yeah, and here there's options. So, for example, an ADO1 device from an antegrade approach is okay. 5 millimeter. You could use an Amplatz muscular VSD device, but that's too stiff. And AVP is another option. So there are quite a few options for this.
What about an ADO2? 6.
ADO2 just about, because it depends on whether it's a 5 millimeter definite or sometimes it's you have to go upsize. So then it may be a problem. And also it's not a very long. On the TOE, we haven't seen the inlet portion magnified yet, whether there's an aneurysm there or not.
Sure.
Can you enlarge or show us the TOE, the view you're showing now? Just see if there's an aneurysm.
We charge with a soft retention cable. Here it's very stiff.
We change with the AGA one.
With less stiffer retention cable.
Make the comparison between the two.
Oui. 7.5 please.
اعطينا اعطيني الواحده نتاعها اللي باش نحطوا فيها. حط لي سيروم هنا ويبارينا هاي حلو. It's a 5-7 device. Lumière, s'il vous plaît. Mais surtout sérum.
The 5.7 or 7.5 device has a left ventricular disc of 12 millimeters.
ضوء يا الاولاد. اي شفت.
Lumière, s'il vous plaît. Donc, here's the
يا اخي
If you could move the camera to your hand, or perhaps, yeah, that's it. Zoom.
You can show us.
donc it's like audio 1,
سلام.
but with the retention, right
Lumière.
retention disc and with the
وينهم الاخرين؟ وينهم الاخرين؟
screw. Donc here,
If possible, we need just one view. We've got split screen of 3.
Yes.
If we can just do one screen and then zoom on the hand and the device.
donc
Ah,
it's like audio 1, but with the retention, right retention disc and with the
That's perfect.
two screw. Donc si we go anterograde, donc we connect the cable here by the right disc. Is if we want to go anterograde, we connect the cable from the left disc.
Yeah.
Donc,
And the 7 millimeter is that it's the waist in toward your right hand, isn't it? And the 5 millimeter
Yes.
toward your left hand.
Yeah.
So which side are you going to attach? This is interesting. Which side are you going to attach?
7 millimeter from here and 5 millimeter here.
Yeah. So which side are you going to attach? The right hand one or the left hand one?
What?
On va attaquer à droite.
We attached from here.
From right.
The left. From the left.
Right hand.
Right hand, yeah, because the 7 millimeter needs to be
Yes.
at the left ventricular side.
Yes. Donc, this device, there is no membrane into the device. Donc,
Yeah, correct.
Yes, ok, c'est bon.
Ok,
Il y a
oui.
l'introducteur.
it's the loader of the. Donc,
لا الجيد ما يتحركش مع نحكي على هذا. هي تتم. ماماتي رنتني أكثر منك هيك. My great mother. Yes.
I think Dr. Tin has joined. If we can get him, because he was having difficulty with his internet, but he is. So I think he's on. Just for any comments, because he's done hundreds of these.
C'est bon, frère.
Yes.
أعطيني.
Bien. De l'eau.
C'est bon. زيدان هي تتفق.
How much heparin have you given?
Heparin,
شران قلت فيه.
15 milligram of heparin.
Sorry, 50 units per kilogram or?
100 units per kilogram.
Vas-y,
No,
vas-y,
50.
C'est bon?
C'est bon.
Ouais, on y va.
Donc,
On y va.
now we change
On libère, réveille, on libère, réveille, on libère, réveille. Pictail. خليها من بعض. C'est bon, c'est bon, c'est bon.
I don't know.
Okay.
Again, I can see Tin has joined, but Tin, do you have any comments? You may have joined late, so that using a 6 French sheath, is this a TalkView sheath or is it LiveTech sheath?
LiveTech sheath.
LiveTech sheath, okay. And a 7.5 MFO device from the retrograde arterial approach.
C'est bon.
Donc,
Attendez. Il faut pas aller plus loin. Hein. Vas-y. Hein.
Now we progress carefully. Donc,
Ouais. Ah, ok. Plus.
there's some resistance. Okay.
Okay. Okay. I think we have, yes. Okay.
You have to show an echo.
Yeah, if you show a
Yes.
split screen, TOE and fluoro.
You can show the yes
The sheet.
the sheet.
Okay, good.
In the right ventricular side. Bon. Ouais. Oui, Trika Bark. Il y a, ouais, Trika. C'est le, voilà. We introduce the device. And the challenging is to have the right angulation to deliver the device.
And the nice thing with this device is that it's got the screw on either side, so it can be approached from arterial or venous side, and that gives you flexibility.
Now with echo, we check the position, the right disc, and we check the tracheostomy valve. Donc we can go
Can you
45
show the
degrees of the.
But without color Doppler.
Aye.
Without color Doppler,
Dr. Quraishi, you are seeing the echo?
Yes.
Okay.
But we need a split screen with fluoro as well.
Nice. Ah ouais. Tu fais le. Vous pouvez passer la fluoroscopie maintenant?
We pull back as close as possible to the.
You are seeing the fluoroscopy?
Now we are, yes.
Yes, okay.
Comment va?
It's quite small, but
But you are seeing the fingers, not the image.
yeah.
Okay. Okay.
If we could make the fluoro bigger and the TOE can be small at this stage.
C'est dans la haute. Est-ce qu'on peut passer la fluoroscopie une autre fois?
You can see the fluoroscopy.
Ah, on est dans la horte là.
We just see the TOE.
Yes.
And the main question here, if you show the long axial view, left ventricular outflow tract view, is whether the left ventricular disc is actually in the left ventricle or involved in the aortic valve leaflets or not.
It's attached to the cable. Color.
We are seeing the right ventricular.
There is no aortic regurg, donc and
left ventricle.
Yes.
But
it doesn't look as if there's any shunt, is there?
Because there is tension on the cable.
Yes,
no?
we can.
Maybe you can give less tension on the cable.
Yes. Tu pousses un peu.
You can push it in a little bit more.
Push. C'est mieux ou pas? Ouais. Bon, normalement, non. Oui, c'est bon. C'est mieux là. C'est mieux.
Et c'est better.
Tu as poussé ou pas? Allez, tout à l'heure, elle était beaucoup plus verticalisée. Less better.
Because
what we have to think.
Yeah, so because it's a bigger sheath, you should be able to do an angiogram to show
yes.
the aortic leaflets.
Contrast, please.
Attends, pigtail.
No. Contrast in the
sheet. Écoute. Contrast أما هنا.
It's too far from the aortic valve. The sheet is too far from the aortic valve.
Vas-y.
So the angio will be probably.
It should be okay because you're interested in the aortic valve function at this stage.
Yes.
There is no problem with the aorta, I think.
The image is very small for us. If you can make the fluoroscopy bigger, my impression was that it looks
like that.
As the cable is
Like that.
Yeah, but make the fluoroscopy image bigger for us, because at the moment we have TOE bigger.
How the
That's it. So now let's see the.
scopy.
Yeah.
Scopy.
So that looks, although it's angulated, the left ventricular disc, position-wise it looks fine. Aortic valve function looks fine, and the device can. If you try and push the cable a little, otherwise when you release it, it should adjust.
Yes, I think so. C'est bon.
you can release. Yes.
We release.
Make the fluoroscopy bigger for us at the moment, and TOE smaller.
Scopy.
لا خليه يشوف ساكو. allez-y.
Scopy.
Bigger.
Bigger.
Allez-y. Allez-y.
هكا.
أي دورة. Okay. It look better.
Yeah, it looks excellent repositioning there or alignment.
Okay.
And now you can do aortogram and
Tu peux voir les cours, Aïchka?
So if we do transesophageal echo assessment now, because that looks good.
She's doing that. Est-ce que tu vois là? You are seeing
Yes.
the good sandwich.
Yes, very good.
Color.
Trick.
Without good. We check for the tricuspid valve.
Tricuspid valve.
Yeah. So now if we could make the, this is complex, make the TOE bigger so that we can see the VSD device and tricuspid and aortic valves.
Bigger. Color.
وانت بدك فتحية. C'est le maximum. It's a maximum for echo.
That looks good now. So if you could show.
Change de. Ouais.
If you show color on tricuspid.
There is no regurg, just.
There's a tiny flow through the VSD device, which is fine. Tricuspid, a little bit better view of that. Otherwise, if you could show a 4-chamber view.
4 chambres. 4 cavités. 4 cavités.
Okay, so it doesn't look like there's any tricuspid regurgitation, so that's good. And then if you could show the left ventricular outflow tract view.
Longitudinal, voilà.
Ouais, excellent.
Color. Longitudinal.
That looks excellent on 4-chamber. And LV outflow view, if you could.
Sans bas.
You systematically do an angiogram after.
Yeah, we do. I would, if there's no issues, I would do an LB angio and then aortogram. So because there you see the transesophageal echo looks good. If you put color on, the aortic valve leaflets look fine. Yeah.
Good.
That's a brilliant job, I think. If we just for completion, if you could do an LV and aortogram, then we're done.
Okay. C'est du produit. Yes. Yes. I think
No aortic rigors.
Yeah, that's absolutely brilliant.
naturel.
I wouldn't use the sheath to get into the ventricle, but if you have a pigtail,
Yes,
Yes, we will.
Can go through this one.
that would be nice, and then we're done. That looks a excellent job so far. If you could ask them to make the fluoroscopy bigger and the T smaller
Oui, j'ai compris.
on the split screen.
حاب تدخل البيكتيل ديريكتومون تبقى ما تنجمش تدخلها لما نحطوا هذه فوالا تيا هاي شايف
Check.
حتى
Yep.
May I make one comment?
Tin, yes, we've been looking for you.
Yeah. Sorry, I am late joining the meeting. But for this case, I see the defects close to trachea valve and far from the aortic valve. And you choose a retrograde approach, is right. But I have one comment. When you deploy the disc in the right side, in the right ventricle, and put back to the septum, we should check the trachea valve before we release the release device. It's most important because when we release device, we cannot correct or adjust the right side in the right ventricle.
Yeah.
Luckily, this case, right ventricle trachea valve looks well. But my experience, I should check very carefully before I release.
On a le temps, on n'est pas pressé.
Very important point, Tin. Thank you.
Zen.
They were very efficient and quick, so they did that before we had a chance to comment.
C'est pour ne pas pour la
Tin, welcome. You've managed to make it. I got stuck as well in traffic, and you've made it as well. You see, this is typical, isn't it? The easiest part of the procedure takes longer, which is crossing Europe. Otherwise, we've got a very good.
Okay.
There you go. Be very careful now as well.
Yes, for
Yeah.
to.
Okay.
C'est bon. C'est bon.
And just remind us, what was the PA pressure, pulmonary artery pressure?
La pression, Isaac. Ventriculaire gauche. Ouais, tiens.
Yeah. Was the pulmonary artery pressure normal?
Right ventricular heart. Right heart catheterization.
Zéro, please. On reprend le zéro. Madame Bourzel, vous vous rappelez, les zéros, ça n'a pas changé ici. Hein? C'est toujours le problème. 30 years after.
Yeah.
Zéro.
Okay, go. Let's see.
Béchir qui n'est plus là, c'est tout.
Eh ben oui. Donc, les
Il se porte bien.
Alhamdoulilah.
Allez, zéro. C'est bon? Allez.
We can't see it.
Very small tricuspid regurgitation we saw.
Yeah, that's okay.
Ok. On fait l'enjeu, hein, c'est pas. On n'a pas eu un bon zéro, ouais.
Hamdi.
Hamdi?
Jamais bon.
Le zéro est bon, oui.
Jamais bon.
Hamdi?
Ouais.
Oui, je crois. Ils n'ont pas de.
Then we can stop.
Ok. We will do the angio. It's okay.
It's okay.
Après, on fera.
Ouais.
Bon. نزيدو حط 15 حط 15 دقيقة
20
15 راح سكوبي عايشك اوكي
لحظة
Allez, on y va.
Okay, super.
I think it's good.
That's a brilliant result. Congratulations to the whole team. That was very efficient, very good. Tin made that important point about releasing the right ventricular disc during the initial deployment and checking the tricuspid valve. That's very important. But otherwise, it's a perfect position, isn't it? And a good result. Tin, any comments as well? If you unmute.
In fact, we had the three VSD or 3 cases to do. We choose this one because because it's more interesting. The first one was muscular and central defect, so I think it's no problem. But this one,
yeah.
Such assistance with mondial experts like you to do and to improve our work.
Thank you very much. Let me just get Tin to say a few words and then we'll finish on this. Tin, go ahead. Oh.
Sorry.
Yeah, I was just going to ask you, what did you think? I know you joined late, but any thoughts apart from the right ventricular disc careful deployment?
This case, I think the morphology of the defect is close to tricuspid valve, and we worried about the tricuspid valve more than the aortic valve. And retrograde approach is the convenience or more advanced for the tricuspid valve. If we deploy the right side disc, and we can adjust it, and we should take a look on echo about the tricuspid regurgitation. And in case the severe tricuspid TR, we can adjust, we can recapture and deploy again, or we can change the direction of the and until we feel it's a no TR and TR is acceptable, and we deploy the right side, the left side is safer. And this case, even though they didn't check, but the final results were very excellent. Everybody happy with that.
All right.
Thank you very much. I want to thank all the team, the anesthesists who are work hard with us. La pharmacienne, par contre, en anglais, j'ai oublié. Pharmacist, because they permit to us to do this act, and the Life Tech because it was our sponsor in this session. So I think all the panel, all the assistants, and
bye-bye.
Next time.
Thank you very much. Congratulations. Well done.
Bye.
We'll move away.
Congratulations.
So thank you very much. That was an excellent start to the morning. And now it's my pleasure to welcome an old friend from Saigon, Ho Chi Minh City, whichever one you want to call it, Nguyen Tin. And he had a little bit of difficulty with his internet, but he's now ready. And we're going to start with telling us about state-of-the-art transcatheter.
نعمل تصوير الكل ولا كيما العادة ولا شيء.
We need to sort out the sound from the catheter lab next.
Salut. Ciao.
If we could disconnect.
Alors, le Covid, il a été transféré ou pas encore?
Yeah, hold on, Tin. We need to sort out the sound.
On coupe le son là.
Okay, hi Jack and everybody. Thanks for inviting me to join the meeting and sharing some of my experience about the VSD closer. I just want to share to you my experience in Vietnam about the VSD closer, who, when, and which device to use. First one, you see, I start doing the VSD closer with the BDA device, and you see it looks very beautiful. But after several years, everything looks not simple like this. We have many problems, many issues, and we want to share to you. First, I show you how I can do the VSD closer. First one, how to make the LV angiogram for VSD. Some cases, the VSD morphology very easy to see on angio, but sometimes we should change the angulation to find the best view for seeing the morphology. For my experience, if BM VSD, maybe we just need the 30-30 LEO and cranial. But when the defect is a little bit higher, I mean close to the outlet VSD, we need to move more LAO and less the cranial. And in case the doubly committed or subaortic or outlet VSD, we choose a lateral view. It means 90 degree without any cranial view. And the second one, when we see the morphology, we think how to cross the VSD. Somebody use the catheter, somebody use the guide wire, cut pigtail, or Chaya catheter. But my experience, accordingly, the angulation between the ascending aorta and LVOT and the defect. You see the LVOT and the defect looks a little bit straight, and you can use the wire. We put the Chaya catheter in the middle of the ascending aorta and use the guide wire crossing easily. And but the problem when you crossing the defect by guide wire, the guide wire tends to go to the right ventricle apex and go up to the pulmonary artery, and it means it means the risk of the tricuspid valve entangling, and so you should avoid the tricuspid valve entangling in this case. And in case you the guide wire to the SVC or the pulmonary artery, it's anyway for me it doesn't problem. Don't try to go to the SVC or pulmonary artery. We make the AV loop, but it's important you see the straight. The loop looks beautiful. This means a straight one on the right side. It means no tricuspid valve entangling. And second, when you deploy the device in the retro antegrade, deploy the disc in the ascending aorta and pull back to the left ventricle. And you should pay attention on the aortic valve. When we pull back the device through crossing the aortic valve, we don't know when the aortic valve open or close. Sometimes when we pull back is when the aortic valve close. We cannot cross, and don't try to pull very sharp. And some cases you see I should recapture the device, make the left side is smaller and pull back into the left ventricle. And for me, aortic valve is very important. We cannot change from the small defect to the aortic valve regurgitation. When the device inside the left side disc, we do ensure, and we see how far the left side disc to the septum, and we know how much you adjust the device into the septum. You see, it's a little bit far. We can pull back a little bit, but it fits well. We just release the second disc in the right side. And when the second disc in the right side, we can see, do ensure again, and we see it's suitable for release. And in my country, there are some different from the Western country or US, but I think we similar to Africa and some other developing countries. Indication for VSD, maybe we agree that the hemodynamic issue, the LV dilatation could be per QS more than 1.5. But some cases, due to based on the morphology issue, some VSD cannot spontaneous closure. Subpulmonic or muscular, no membranous septal aneurysm or residual VSD after surgical repair. Doubly committed VSD with the risk of the aortic valve prolapse or the aortic valve regurgitation. We close it for not closing the defect, but also for preventing the aortic prolapse and aortic regurgitation. And endocarditis also the big issue in the developing country. And high risk and other specialism, the family requirement, patient requirement, and social issues, study, insurance, and working, many things, and depending on. And which device is best for the patient, the very membranous VSD? You see the many devices, but how can we choose? I think there are three main bonds for very membranous VSD. First one, the aneurysm. Second one, the distance to aortic valve. Third one is the size of the defect. If the patient there are no aneurysm with VSD, I think there is a simple case called the single opening exit in right ventricle. We can choose any devices. You see the small hole, the aneurysm, we can choose any devices here. You can choose the ideal 1 or the ideal 2. I think small hole we use ideal 1 or bigger hole which small hole we use ideal 2, but the bigger one we use ideal 1. It looks beautiful. If the patient have some space, so aneurysm, it means the aneurysm, it means the defect close to the tricuspid valve. And it means the defect is far from the aortic valve. And with the aneurysm, that we have some space for the device. The device can go inside the aneurysm. But we have problem with the tricuspid valve. And the other problem is the opening axis with aneurysm. The opening axis may be simple, maybe the very complicated one. You see some cases the aneurysm looks very simple or complicated, but for my experience, just close from the left side, everything from the left side. We don't mind how many opening axis and how about the aneurysm in the right side, and we can close totally. But some cases, the aneurysm, we cannot see clearly the morphology of the defect. You see it, you cannot see clearly how many opening exist in the right side, and the defect is a little bit large, not easy to close from totally. You see here, I close by the BFM coil, you can see many opening exist, but only one device can close. I can use the Occlutech device with retention this a little bit large, and also that we can close totally. But some cases, the very big entrance, we can use a coil but cannot cover, and we use other device, maybe more extra device to close. And here you see the one device not cover enough, we put a second device to cover all. And the second one is the distance from the aortic valve to the defect. If the patient has some aortic rim, it is a simple case. You see, we can put any device, ideal 1, ideal 2, or even though the coil. And you see, it's a simple case for Occlutech device also okay. But no aortic rim is a big problem. No aortic rim, which means no aneurysm, because the defect close to the aorta, far from the tricuspid valve, and also related to the aortic valve prolapse and aortic regurgitation. You see here some mild prolapse, and you see mild regurgitation. It's a very difficult case for us to make the decision close by device or surgical care repair. You see some cases prolapse of the leaflet on the sinus, and you see the tricuspid valve aortic valve regurgitation. And on angio, you see some prolapse is mild, but some cases very severe. And how can we deal with no aortic rim? We need to use the very flexible and soft device, and BFM coil is suitable. Or some cases, ideal 2, very soft, and it looks very beautiful. And how about the outcome? We did almost 15 years with the VSD closer. We have some problem with outcome. First one, a heart block. Everybody worry about it. Second, aortic valve. Third one is the tricuspid valve and residual function and LVOT, RVOT obstruction. Aortic regurgitation, you see, you can see due to the device. But aortic regurgitation may be before procedure due to prolapse, or during procedure when we crossing the aortic valve, or we use a device crossing the aortic valve, and after procedure. You see, before procedure, maybe you see the prolapse of the aortic valve and sinus. And but in this case, if we try to close by ideal 2, and you see the AR still there and not become worsening after the device closure. In some cases, after the device, the AR is disappear because the device lift the prolapse valve up, and we can get a good result. But not all the case. And during procedure, you see the device crossing the aortic valve, as mentioned before, is high risk for the aortic valve. This case, you see the device looks very beautiful, but TR is a very strange check. And we send the surgeon to open, you see the aortic valve tear by device. It's a technical issue when we do.
In the interest of time, I might have to ask you to speed up here, please.
Yeah, and And you see due to the device, and this device IDO1 is a very steep disc in the left side, is a high risk for the aortic valve regurgitation. And if the patient have aortic cream, is okay, or even though the patient have aneurysm, the device go inside the aneurysm is far from the aortic valve, and we don't worry about that. And tricuspid valve, as I mentioned before, is very important for the aneurysm. And you see IDO1 is the very high risk for the because the length of the IDO1. The tricuspid valve may be before procedure due to the left ventricle to right atrium shunting. And you can see this case TR before, but after the device closure is no TR anymore. But who is high risk is aneurysm is a high risk for the tricuspid valve. Or during we make the IV loop, we also have a problem with tricuspid valve. And even though the device go inside too much into the right ventricle, you see this case, the TR, and after adjust the cable and the guide wire, the device still, and after release also still TR. And I send to the surgeon, and you see the device too much in the right ventricle. It means the length of the IDO1 is problem. Hemolysis and restitution just happen in the BFM coil, and we just have some case with high risk BFM coil. And now we try to close by IDO2 for totally closer. And who is risk if the patient restitution with a velocity more than 3 meters per second is a high risk. But and the heart block, I don't have any heart block. I start using the the IGA VSD closer, but one case heart block, and I changed and no heart block anymore. And now I don't have any problem with heart block. And my conclusion, until now we don't have all the one device can close for all the VSD, very members VSD. And also we don't have a uniform morphology for all the BM VSD. And of course the different device can bring the different result, and different technique and different interventionists can bring the different result. Thank you very much for listening.
Right. Thank you very much indeed, Tim. That was very comprehensive and some excellent tips. We are a bit running behind. So, but very briefly, if there were two messages that I would ask you to give. One is, not everybody is obviously as good as you and have the same experience as you with perimembranous VSDs. But if you had to give important words of caution, which VSDs should people avoid? And which ones would you be a bit more cautious about when you're closing them?
The VSD, I'm very worried about.
Yeah, you close a lot of VSDs that majority of people would not. So if you had to give words of caution, what would they be?
My caution is the VSD inlet extension. You can see maybe the aneurysm make the defect a little bit smaller, but the entrance very large. And we put the device, but the aneurysm is not sometimes not stable to keeping the device. And second one is a high risk for heart block, and the inlet extension should be avoided. And outlet VSD also outlet with the large defect, the through hole more than 6 mm. I think this surgical care case. Not we don't try to do this way. We may damage the aortic valve.
Yeah, and the prolapsing coronary cusp or leaflets, VSDs.
Prolapse is not big problem. Prolapse is more than 50%. I think the right coronary cusp prolapse on the ventricular septum more than 50% by itself. I think it's severe prolapse we cannot do.
Okay. All right. Tim, thank you very much. We must move on, and it's my pleasure to welcome Maurizio Marasini. I can see him, and he's going to talk to us about complex systemic pulmonary artery shunts. Maurizio?
Hi, Jacques. Nice to meet you. I try to... Okay?
Yep.
Okay. Thank you very much for this invitation. My talk today is transcatheter treatment of complex systemic to pulmonary shunt. The first case of transcatheter closure of perimembranous VSD was reported by Jim Locke in 1988. This is my first experience with racing closure of residual perimembranous VSD in my institute in 1991, and I'm sure I remember very well. It's a very complex procedure. It's true, was 30 years ago, but also today, perimembranous VSD is usually considered a little bit complex procedure. Compare an example to atrial septal defect closure. But this is not always true. This is an example. Okay, 15 years old girl, 42 kilograms, with mild to moderate size atrial septal defect with short aortic rim. It was closed after calibration with a 12 millimeter Amplatzer atrial septal defect occluder. No problem, everybody is happy. However, in the afternoon, a young clinical fellow performed an unuseful echo because the patient is completely asymptomatic, and they called me, Dr. Marzini, the device is not in place. In fact, the device is embolized in descending aorta, as you can see here and here. What will you do? So, of course, we have retrieved the device. Is not so easy, but anyway, we have retrieved the device from the descending aorta without problem. Here the device. Okay. The aorta is okay. Sorry. Okay. We perform another TEE and confirm the presence of a single atrial septal defect with a new calibration test and maximum stretch diameter of 14 millimeter. So what do you do? We choose to stop the procedure and we choose to surgical closure of the VSD because there was not only a poor aortic rim, but also a malattached septum primum as described by Robert Henderson. Here you can see the accessory attachment in left atrium, and this is exactly the condition of our patients here in 0 degree, here in 19 degree in TEE, and here the 3D ATE echo. And this condition is an increased risk of embolization on the left side and increased risk of erosion of the atrial wall. Then we stop the procedure. Another example, the old image, 7 months old child, 7 kilograms with moderate size atrial septal defect, but with a huge right ventricular volume overload, and with a membrane, a linear structure in the left side, in left atrium, but without any gradient and pulse Doppler, and without any turbulence of color Doppler at color Doppler. What do we do? So we have perform a static occlusion test of the defect with simultaneous recording of the left atrium pressure, both in the upper and in the lower chamber. And finally, given the absence of any gradient, we close the defect with a 10 millimeter atrial septal defect Amplatzer occluder. This is the immediate result, a very big device for a small child. This is a 2 years follow-up cardiac catheterization show a normal pulmonary artery pressure, no gradient between wedge pulmonary pressure and left diastolic pressure, no gradient in the left atrium, and no residual shunt. And this is the last echo, 19 years later, which show normal, no shunt, residual shunt here, and no gradient in left atrium. PDA, this is the first multi-center study on PDA occlusion with a Raskin device published in 1987. 165 patients with a success of 66%. So today we have a lot of device for PDA, detachable coil device, PDA unplatzer or unplatzer-like device, PFM knitting coil device, or piccolo device. And the future now, the limit now is how much we can put the technique, we can go to close the PDA in very low birth weight, preterm, newborn, and infant. But sometimes we can see some particular case. A 5-year-old Nigerian child, 16 kilogram, with a PDA, but a large aneurysm of the PDA, with an aortic open of 32 millimeter, maximum diameter of the aneurysm of 35, a kinking here, and another aneurysm, smaller aneurysm at the end of pulmonary, at the end of the ductus on the pulmonary artery. What do? We choose to put a cover stent, a CP stent cover stent 1640 by 45 millimeter, mounted on the bead balloon catheter in the aorta. Here, this is left pulmonary artery, this is the pulmonary end of the aneurysm, and another cover stent 60 millimeter by, I don't remember, 25, I don't know, in the left pulmonary artery to completely occlude the PDA and completely excluded the aneurysm. Here are the final results. And finally, this fistula. We can see a lot of fistula. The coronary fistula, a shock for this is probably the leading expert in the world. Systemic artery to systemic vein fistula, here in a fistula between anterior thoracic artery and supravena cava. Fistula from descending aorta and right lung, or pulmonary artery venous fistula, large pulmonary artery venous fistula. Almost all this fistula can be closed with several kind of the device, macro coils. Here a cover stent in the anterior thoracic artery, multiple microcoils here, and both coils and unplatzer device here. But sometimes there is, you can see a particularly challenging case. 11 years boy, 50 kilogram, come from Ukraine for a large pulmonary artery venous fistula with a severe stenosis. We can see here the fistula, but the open or the fistula is very, very large and short. It's a window between the RPA and the ipsilateral inferior pulmonary vein. We perform an occluded test with a tie shock 10 millimeter or 12, I don't remember. And finally, we choose to use a device to close completely the fistula. We use an unplatzer ductal occluder of 16 millimeter is here before detach, I'm sorry, and here after detachment, with the device perfectly in position with completely occluded fistula. So my conclusion, sometimes transcatheter occlusion of systemic to pulmonary shunt can be a very challenging procedure. In this case, the final result mainly depends on the correct evaluation of the anatomy and on the right choice of the best device. And by the way, we can always be able to turn even the simplest of the procedure into a very complex case. Thank you very much for attention.
Maurizio, thank you very much indeed. That was an excellent collection.
Sorry.
Excellent collection of cases, unusual, rare ones, and some really good tips. Are there any questions from the panelists to Maurizio, because he's really given a lot of examples there. Very quick questions if there are any, and quick answers. Elia, so were you going to ask a question or?
Probably for the first case of ASD closure, for the 12 millimeter VSD closure, ASD closure, the first case. Probably since the procedure, the right disc or the both discs were probably rather than in the left atrium, rather than insufficiency of the rib.
Yes, it's true. In case of malattachment of the septum primum, the right disc is not in the true, the upper extremity of the right disc is not in the true septum, is in the malattached septum. And this is the reason of the embolization. It's very difficult to branch both extremity of the upper rim of the defect in this case.
Yeah.
All right, Maurizio, thank you very much. I think we will move on, but brilliant talk, really grateful to you.
Thank you.
So it's my pleasure now to welcome an old friend who, with the COVID going on, we work in the same department, but we haven't seen each other for a long time. Gerline Charland, my fetal cardiology colleague, and she's going to talk to us about for which fetal heart defects should we intervene on and when. Gerline, welcome.
Thanks very much, Shaq. Nice to see you, even though it's remotely. I hope you can all see my screen. Can you see my screen?
Not yet.
Not yet.
Okay, let me try again. Just bear with me.
Need to share.
Yeah. I think that's what I did wrong again. Right. So hopefully now you will see my screen.
Yep, that's it.
Let me just make it bigger. Okay. So my talk's a little bit different from what you've all been hearing, but still, I think, equally important. So which cardiac lesions do we intervene for and when? So fetal therapy is usually considered if the procedure is going to be either life-saving, so it will improve the survival, it will prevent or improve fetal hydrops, or prevent a spontaneous intrauterine loss. Or it might change the natural history to improve postnatal outcomes. So this might be by improving growth of cardiac structures or improving the cardiac function. So essentially for structural abnormalities where fetal intervention is undertaken, it's usually the obstructive lesions, aortic stenosis, but usually at the severe end of the spectrum, not all cases of aortic stenosis, pulmonary atresia with intact ventricular septum, some cases of critical PS, and some cases of hypoplastic left heart syndrome where the atrial septum is very restricted or intact. We obviously undertake interventions in fetal life and treatment in fetal life for arrhythmias, but that's not the topic of the talk today. So the progressive nature of both left and right heart obstructive lesions has been very well documented in fetal life. And indeed, it was the initial observation that critical aortic stenosis can progress to hypoplastic left heart syndrome that led to the very first fetal intervention for aortic stenosis in fetal life. And this is the type of progression we see. So on the left of the screen here is a 4-chamber view from a baby with a critical aortic stenosis at 21 weeks of gestation. And you can see the left ventricle here is abnormal. It's poorly contracting, it's dilated, the walls appear echogenic, which would correlate with endocardial fibroelastosis. And what we would expect is that this chamber will not grow and the right side of the heart will grow around the left side. And indeed, in this baby later in pregnancy, at about 32 weeks of pregnancy, you can see now that the left ventricle really does look hyperplastic. The right ventricle has grown round it and is forming the apex of the heart. And if you were to measure the left ventricle here, it's probably the same size as it was at 21 weeks, and it just hasn't grown. So just to say, though, that although we think about intervention in these types of cases, it's not contemplated in all cases of aortic stenosis. There will be some where it's not suitable. Either the case is too severe or it's at the better end of the spectrum and will be fine without an intervention. So that's important. The ones we would consider it in is cases of aortic stenosis which showing features of evolving into hyperplastic left heart syndrome. The rationale being that if you can dilate the aortic valve before you have irreversible left ventricular damage and cessation of growth, there might be some hope for recovery of function and growth can resume. And usually the aim of the intervention has been to avoid a univentricular circulation in aortic stenosis, but sometimes other reasons. I know it has been done as a salvage procedure, for example, in some cases associated with high drops. So the initial step is to predict which cases of aortic stenosis will evolve. And many years ago now, 2006, the EHLH scoring criteria was defined, which is the evolving HLH scoring criteria, to define the features that are associated with progression. And the predictors of progression in mid-gestation are really as you would expect. So abnormal left ventricular function, as shown in this image here. We can actually see an abnormal aortic valve here. Reverse flow in the aortic arch. So this is the view in the fetus showing the pulmonary artery and duct here. This is the aortic arch, which is hyperplastic and has got reverse flow. And in this clip, you can just catch a glimpse of forward flow across the aortic valve. Abnormal monophasic mitral valve flow, as shown here, and a reversal of the normal shunt at foramen ovale level. So in the fetus, the normal shunt is usually predominantly right to left. But in these cases with severe left heart obstruction, the shunt is reversed and becomes left to right. So having identified fetuses that we think are going to evolve into a hyperplastic left heart syndrome, they're not all going to be suitable for an intervention. So the next step is to try and pool out the ones that you think actually have a potential for achieving a biventricular circulation. And the threshold scoring system was identified and defined to try and do this. And this uses a variety of left heart parameters of the left ventricle, aortic valve and mitral valve to try and get a score which is used to help to predict which fetuses have the potential of actually achieving a biventricular outcome to help select cases. And more recently, the International Fetal Cardiac Intervention Registry has put together the EHLH criteria, the threshold scores, and a few other things to make some echocardiographic criteria for identifying fetuses that would be suitable for an intervention. We don't have time to go into this, but anyone who's interested can obviously go and read about it a bit more. So here's just another case where we might think about it. Here is a four-chamber view. We can see the left ventricle here is a normal size, but it's not contracting very well, but it's not too bad. And the walls here are not echogenic. It's just starting to become a bit globular. there is quite significant mitral regurgitation. And one of the things I would say is that probably for people undertaking intervention, it's quite important to assess the mitral valve and give it some thought, because many of the problems babies have after birth are related to the mitral valve problems after postnatal interventions. So this baby had mitral regurgitation at a high velocity, abnormal inflow into the left ventricle, and this one actually generated an aortic velocity of 1.5 meters per second, which is actually high in a mid-trimester fetus. So that's for aortic stenosis. The other two main things are firstly pulmonary atresia with intact ventricular septum, and as I said, it could be very severe pulmonary stenosis. When we make a prenatal diagnosis, we try to predict, is this baby going to have end up down a single ventricle pathway, or is the biventricular circulation likely or possible in this situation? We try and establish the type and level of obstruction, whether it's membranous or muscular, what types of surgery we think or intervention we think are going to be possible after birth. Is the right ventricle adequate? And those babies where we predict progression could occur, so that we might be able to have a biventricular repair if we intervene, but we go down the single pathway if we didn't, might be considered. But the numbers for pulmonary atresia are much less than those for aortic stenosis, so it's often hard to make a judgment. So this is a fetus at 20 weeks of gestation. This baby had pulmonary atresia. With intact septum, this is the right ventricle, which looks abnormal. It's poorly contracting, but it's a good size. And this is the same baby later in pregnancy at about 30 weeks of pregnancy. This baby did not have an intervention. Same baby, and you can see now the right ventricle is starting to look more hyperplastic, more hypertrophied, and more abnormal. So this progression is well documented during fetal life. And lastly, the other main group that has been considered for fetal intervention are babies that have hyperplastic left heart syndrome with an intact or highly restrictive atrial septum. This is a very high risk group in already a high risk diagnosis, and they have the worst outcome of the group. The intact septum means there's no outlet for the pulmonary venous flow, and it can lead to irreversible damage of the pulmonary vasculature and lymphatics. And what we often see is very dilated pulmonary veins, which we're seeing here. Here is a very thickened, virtually intact atrial septum in the context of hyperplastic left heart. Here's the hyperplastic left ventricle here. And then we use the pulmonary venous Doppler to try and help us to establish that it does look like it's intact, where we get this abnormal trace where the diastolic flow is diminished and we have reversal of flow during atrial contraction. So this would be a typical appearance. So in these babies, fetal atrial septostomy or a stent have been advocated to improve the outcome for this high-risk group. But I would say that in some of these babies, the lung damage may already have occurred, and it would be important to look at the lungs before embarking on a intervention, and fetal MRI has been used to try and do this. So just coming towards the end now, so one of the things in my title was the timing of first intervention. We have more information about aortic stenosis than any of the other interventions. Fetal interventions have been performed from 19 weeks of gestation onwards, but it's usually later, usually sort of somewhere between 23 and 30 weeks for the first intervention. And it will, of course, depend on the timing of presentation, at what point the fetus gets referred to you, and the echo features. And for aortic stenosis, you can see in various studies, it's ranged from about 23 weeks to nearly 27 weeks. Important to consider obstetric guidelines for invasive procedures and make sure you've thought about what would happen if there was a premature delivery and labour triggered by the procedure. So just finally to conclude, I just wanted to make a few comments. I think overall techniques and immediate outcomes for fetal intervention have improved. Case selection is very important, but I think still can be very difficult and very borderline. I think it's fair to say that effectiveness is controversial. We don't have a randomized controlled trial to look at the benefits, and people tend to publish their good results, not always their bad results. We do need to have long-term outcome to make further assessment about effectiveness. And I think neurodevelopmental studies are very important as well. We need to address that side of things. We should also remember that the perceived benefits of prenatal intervention should be weighed against the improving postnatal treatment options. When we first did the intervention for aortic stenosis, we didn't have treatment options for hypoplastic left heart after birth. We were not doing the Norwood at that time. So things have changed. And beyond that, the postnatal management strategies actually play key roles in ultimate outcomes. So if you're embarking on intervention, you need to make sure you have a good postnatal management plan for those babies. And finally, the risk to mother and fetus is not zero, and appropriate and actually honest counselling for the parents is important. Their understanding and their willingness and compliance is going to influence whether we undertake an intervention or not. So thank you very much for listening to me.
Thank you very much indeed, Gertie. That's very comprehensive, very thought-provoking as well. We are a bit tight for time. So very briefly, are we doing a disservice to some of these patients who we're pushing to two-ventricle repair? They have hybrid procedures and then eventually two-ventricle repairs, and then later on finish up with pulmonary hypertension and persistently impaired left ventricular dysfunction, all because we've been aiming for that two-ventricle circulation from the fetus.
Yeah, I think that's a really important comment, Shak, because I think some of these babies would probably have been better off going down the single ventricle pathway, and to have a good single ventricle result is better than some of the things that we've put them through to have a biventricular circulation, which they may not actually end up with. So, yeah, I think why case selection is so difficult. It's very hard.
Yeah. Okay, thank you very much. I see Hala there, so she needs to say what final say before we move on to the next talk. Hala, welcome.
Hello, welcome. Just to say hello to Mrs. Charles and
hello.
Guided my first steps in fetal echocardiography. It's a real pleasure for me. It was during my days in the department of Professor Qureshi. So I never thank you enough. I'm very happy to see you again, and I wish to see you in our country. So it would be so wonderful if you come next year. I hope. It was wonderful. Yes, it was my first book.
Hala, you get rid of COVID and we'll be there. All right. Thank you very much indeed, Hala, and thank you, Gerline, for that wonderful talk. So my pleasure to introduce Adam Kolesnik from Warsaw, Poland, for the last talk, which is an interesting one as well, and that's 3D medical modeling to improve managing complex congenital and structural heart defects. Adam, welcome to the meeting.
Thank you, Jacques. Thank you for the invitation for this meeting. It was my pleasure to hear all these speeches. And first of all, see you, all old friends. So this is a short presentation on medical modeling. Medical modeling for me is a part of our multi-modality imaging. So we are using a lot of modalities to see what's going on in the heart. And we use them not only for diagnosis, but also for planning, simulation, and guidance of our procedures. So 3D modeling at our institution started, as you can see, like 5 years ago. And now we have a full 3D printing facility. We use it for several purposes. Communication with patients and their families is one of them, but I think the most important part is the visualization of difficult anatomy and planning of surgical and interventional procedures. For very simple presentation of anatomy, what you really need, for example, for parents or students, is a cast of the blood pool in the heart that you can obtain by computed tomography imaging or MRI. So this is the example of totally anomalous pulmonary venous drainage to the coronary sinus. Very simple model that you can have with a very simple printer and very simple software. But it's more complex when it comes to the decisions. For example, like in this case of double outward right ventricle, you have to decide, is it possible to make it biventricular heart, or you have to go for univentricular palliation. In order to have a good model, you need a good entry data. So the data sets have to come from computed tomography, magnetic resonance imaging, but in some extreme cases, you can also use 3D array. 3D echocardiography is possible also to use to create models, and in some centers, they combined computed tomography with 3D echo to get an image of the cardiac valves that are invisible in other modalities. What's important, the quality of imaging data, it's what defines the quality of your model. So they have to be gated images. We have to remember that the spatial resolution results in details of this model. So very, very thin layers have to be used. It's important to plan the examination if we need right heart, left heart, or both. So it has to, the data set has to contain one phase, both phases, or you have to just remember what you want to have in this model. And because of that, occasionally we have to do a special scan only to create the model. So it may result in increased radiation dose and also increased contrast medium volume. The segmentation is done in using the software. We are using Mimics, but there are some other vendors too. What's important is that I think it should be like officially approved software with FDA approval, CE marks, because this is important for our decisions. And the model always has to be validated against the original data set. So we have to be sure that what we see is what was really visible in our initial scans. And then we can create this model and we can print it. This is the case that taught me a lot. One of my first models of the pulmonary arteries link, you can see the trachea here, and this is the left pulmonary artery coming out of the right pulmonary artery behind the trachea, and the trachea looked so narrow here, and the surgeons resisted to operate. This child died. So now I think that we all understand at our hospital that this is part of our medical documentation. It can influence the therapeutic decision, and we take it very seriously. You don't really have to print these models because for telemedicine, you can use three-dimensional PDF files like this one. You can see the model, you can rotate it, and in many cases it's enough. And now what we are using is the internet application. In our case, it's the Mimics viewer, when you can see not only the model, but you can also check if it is really what was visible in our CT images. And recently, a new tool is the virtual reality. And I think this is very important. And we will use it more and more often because you can see three-dimensional image and you can rotate it, you can enlarge it, you can cut through it. So I think it's really valuable. And some other options are available too, like mixed reality when you have it projected on the body of the patient, or holography. So I want to present some cases. This case is one of my favorites, with the child with large muscular ventricular septal defects diagnosed in utero, and then also the hypoplastic left arch, hypoplastic aortic arch was diagnosed. As a neonate, it underwent the reconstruction of the arch and the closure of the VSD, but also banding of the pulmonary trunk due to large residual shunt. At the age of 2 months, the child underwent balloon angioplasty for the recoarctation, but at 7th month, he still was in the ICU, and there were signs of increased pulmonary blood flow, and the surgeons said that they can't reach this defect really, so there was no surgical option. So we printed the model, and here you can see this defect on the left ventricular side, and this is the residual defect on the right ventricular aspect. And again, this 3D PDF helped us a lot. We could measure the entry to this defect, which is 22 millimeters almost. And we simulated the device that could close it, and it came out that it needs a 10 millimeters waist and 22 millimeters discs. This is another measurement. You can see that the true defect is like 10 millimeters. We also performed the simulation of the fluoroscopy view that you can see here. And this is this very same defect on angiography. And then we close it with a conar device 12 by 10. So as you can see, a large conar device that we used with very good result. This is another case, a aortopulmonary window, a very small model, and again, conar device that we wanted to close it with. We wanted to close it by intervention because this child was very, very sick. There was a heart failure, coronary steal. Surgeons were afraid to put it in the extracorporeal circulation. So we closed it with 7 by 5 conar MFO device with some residual shunt that persists, but still the child is doing well and is growing. So we are able to fix it based on the model. In this case, this is the coarctation, and so we simulated a stent. We prepared something like a virtual stent that we put in, and you can see the stent here, this blue thing, and the contour of the stent is here. And you can see that it fits well and that there is no conflict with other parts of the heart, like, for example, the bronchi. So it's also very, very useful. And of course, there are also other applications of 3D modeling because, for example, what we know as the heart or vessel navigator, the overlay systems with 3D images, they also based on segmentation of CT and MRI datasets. So it's more or less the same. And of course, intraprocedurally, you can also use holography or mixed reality, and this is developing. Computational fluid dynamics to present flows in the models is, I think, developing very rapidly now because it allows us to foresee what will go on in the future, and our challenge is to have the possibility of segmentation of 4D datasets to have beating heart models, and in some centers this is already available. So thank you very much for your attention on behalf of myself and the entire team of our department. Thank you.
Thank you very much indeed, Adam, for some superb examples of new technology being used. Really excellent use. And that's using the mimics, did you say, materialized software?
Yes, we are using materialized software.
Yeah. So it's not essential, I think that was your message, to do printing of models. You can do virtual assessment and 3D reconstruction on the computer. Is that correct?
Yeah, I think this is very important because usually people associate 3D modeling with 3D printing. It's really much easier, and you can have an internet database with the models, and you can just call your colleague and tell your surgeon, okay, this is already in the database, please take a look. And he or she can take a look on a 2D screen, or they can put on the goggles and see it in VR. So I think it's much better than printing.
Okay. Are there any last minute questions, because we've overrun a little bit, from anybody in the panel? Habib, you had a question, I think.
No, it's not a question, Shaq. It's just something to show.
Oh, right. Okay.
Can you run the short video, please?
I studied at Manchester Medical School, and maybe I needed that sort of stimulus, like the sixth form college principal. But even in the medical school, the dean on one occasion asked me what I wanted to do when I qualified, and I said I was thinking of hospital medicine. I was still trying to work out what specialty to pick. And the dean said, well, there's no point in you doing hospital medicine, you won't succeed. You should go into general practice.
Right.
Okay, that was it, Shaq. It's a podcast about Professor Shakil Qureshi life. I have seen it a few times, and it is really an amazing podcast. Really captivating. If you start, you cannot stop seeing it, and it's full of lessons and inspiration. So I encourage you to see it. You will know more and better Shaq. Shaq was, as you know, an exceptional person. So thank you very much.
Oh, thank you very much, Habib. That wasn't a question. No, thank you. All right. So, Adam, again, thank you very much for that excellent talk. That's thrown me a little bit. So, I think we've done the session, Habib. There's a lot of VSD case was superbly demonstrated. And then obviously we've had these world expert talks as well, covering different aspects. So thank you very much to everybody, and over to you for the final word.
Thank you so much. It was great. I'm not a pediatric cardiologist, but I have learned a lot. I have followed every single presentation. Thank you so much for being with us for this Congress. And please stay with us for next session. Now it's a break, and we're going to be starting the restart of the program at 11 a.m. with a live transmission from Stockholm on TAVI, if you're interested. Thank you very much.
All right. Thank you very much indeed.
Thank you.